And so we're going to kick it off with one of my favorite providers and speakers, Dr. Andrew Talal. Dr. Talal is a leading hepatologist and innovator in hepatitis C elimination. He has pioneered telemedicine models of Hep C care, bringing treatment to rural and underserved communities, and has been a tireless advocate. He was on the scene when I first came on 20 years ago. Not that I'm saying you're old, Dr. Talal, but he's just been a great mentor, and he's been a pioneer and somebody who's been so tirelessly working for these people and for this cause. And so, bringing treatments to underserved communities has been a tireless advocate for integrating harm reduction into healthcare systems. His work shows the power of combining science, compassion, and equity to reach those most impacted. So please join me in welcoming Dr. Andy Talal.
Thank you very much. And I'm pinch hitting for one of my trainees, Tony Martinez, who was supposed to give this talk, but was not able to, which is maybe why something kept him in Buffalo. I'm going to give an overview of where we are with hepatitis elimination, A, B, and C today, and discuss some of the recent changes to dosing for substance use disorder treatment in order to hopefully promote the harm reduction theme. These are my disclosures. So let's start with hepatitis. Let's start with hepatitis A. So in 2020, the CDC modified the targets from previous reports to align with the Division of Viral Hepatitis 2025 strategic goals and the U.S. Department of Health and Human Services Viral Hepatitis Strategic Plan for 2021 through 2025. The data used for measuring the progress towards meeting the 2025 goals are based upon the 2023 measurements. So if we look at hepatitis A, we've done pretty well with hepatitis A. As you can see here on the bottom axis are the data through 2023, 2013 through 2023. You can see that there was a decline over the 4 years, as well as the levels were actually below the target set for the first time. However, it remains there. With hepatitis A, there remain outbreaks, and as you can see here, in 2023, 6 states declared an end to their outbreak, while 3, Indiana, Pennsylvania, and Maryland, still continued to discuss that their outbreaks had continued. In terms of hepatitis B, what we see here is that since 2020, new infections have actually remained around 1,400 14,000 per year annually, and surpassed the annual target for 2023. And changes in healthcare seeking behavior and testing during the pandemic may actually explain some of the decrease here. And persons, and this slide shows the progress towards the 2025 goal was 40%. The 2023 rate of reported new HBV cases among persons aged 18 to 40 years was 40% below the 2025 goal of 1 case per 100,000. And so the idea here is to reduce the rates among people who inject drugs. And finally, in terms of last but certainly not least, are deaths. And how have we proceeded in terms of deaths? Well, towards the 2025 year goal, there was a 16% reduction from the 2023 rate of hepatitis deaths needed to meet. So they decreased to 0.37 deaths per 100,000 population, and the among non-Hispanic Asian Pacific Islanders, there was a need to continue to decrease. The rate was 1.84 over 100 per 100,000. So remains pretty high compared to the national average amongst that subgroup. And although there's been some efforts continue to be needed in terms of screening, diagnosis, and access to care to further reduce those deaths. So let's talk about hepatitis C. Can you advance the next slide, please? Next slide. Yeah, so in terms of progress, there has been a 49% reduction in the estimated number of new cases in 2023 that was needed to meet the 2025 goal of 35,000 estimated infections. So there's been some decline, but not a whole bunch, not as well as we've done with A and B. And the targets remain relatively stable between 2022 and 23. And I think the stable rate of new infections highlights the need to continue to advocate in this area. If we look, next slide, please. If we look specifically amongst people who inject drugs, there was a 35% reduction from the 2023 rate reported of new HCV cases of 1.7 case per 100,000. And the rate of new cases among persons aged 18 to 40, which is a proxy, declined for the third year in a row, but remained among the annual target. So many of you may remember some years ago, it was identified that individuals aged 18 to 40 became the largest population or the population subgroup with hepatitis C, surpassing the baby boomers. And it's good to see that that declines in the rate of infection in that subgroup have continued. And so harm reduction may be continuing to these observed changes, and changes in drug practices, shifts, for example, from injection to inhalation, and other prevention initiatives such as syringe service programs and treatment for substance use disorders may also be helpful. I know in Buffalo, we recently did some focus groups with patients at a methadone program, and they were reporting that a local agency is actually bringing clean needles to people's houses. There are now community paramedics in parts of the country that will bring the Hep C medications to people's houses. So I think this idea of meeting people where they are continues to evolve and may be partially responsible for some of the improvements in hepatitis C decreases in hepatitis C reported cases. Next slide, please. In terms of deaths, there was a 16% decrease below using the 2023 data, below the 2025 goal of 3 deaths per 100,000. There was a 7% reduction in terms of HCV-related deaths among non-Hispanic, Asian, Pacific Islanders. And there was an 18% decrease in HCV-related deaths, 4.92 deaths per 100,000. A lot of this is due to the advent of the well-tolerated direct-acting antiviral medications that many of you are aware became available in 2014. And so, although the annual target was met in terms of the overall of the deaths, the death rate among non-Hispanic Black persons remained higher than the national rate. And so really targeted efforts are needed to increase awareness of the infection, screening, early diagnosis and access to care, and treatment to further decrease the death rate among non-Hispanic American, Indians, Native Americans, and Black individuals. Next slide. So many of you may be aware that 4 months ago, the Senate, specifically Van Halen and Bill Cassidy, introduced a bill, the first time an HCV elimination bill. And so this has become sort of a buzzword or a rallying cry for further interventions to eliminate, and I'd like to discuss some of those now. So next slide, please. Some of the very specific suggestions within the proposed legislation are exactly what we're doing today, building partnerships that amplify prevention, testing, and treatment strategies, build capacity within jurisdictions to collect and analyze surveillance data to identify and investigate transmission networks and outbreaks. Without adequate data, how are we going to know where we need to be targeting? Develop trainings, technical assistance, and other clinical decision support tools for primary care and other healthcare providers to support and implement screening, testing, and treatment. And I think AI brings a lot of opportunity in this area. For people who are not routinely practicing or treating hepatitis C, AI may offer opportunities. More work needs to be done. And develop public health campaigns to raise awareness and encourage universal screening, such as working with your Department of Health. Next slide. Increase awareness to treatment and vaccination by improving care navigation and integrating services into primary care and into pharmacies, or I would say substance use treatment programs as well. Promote universal screening for all adults at least once in their lifetime and every pregnant woman during each pregnancy. Promote periodic testing for persons with recognized exposures and risks, and promote testing of all infants and children perinatally exposed. And so those are some of the ways in which I think we're going to be able and be successful in eliminating not only hepatitis C, but other hepatitis. Next slide. So let's talk a little bit, in the last few minutes, I'd like to talk about some changes in that SAMHSA updates to the 42 CFR Part B that seeks to dramatically expand access to life-saving medications for opioid use disorder and at the same time reduce stigma. So I think some of these next slide. Next slide. So some of these changes are deal with in the area, can be thought of in the 5 different areas: the area of accreditation and certification, patient evaluation and treatment, dispensing of medications. This includes expanded use, as I'll discuss in a moment, of telehealth, compliance and oversight, and finally flexibility and this increasing use of telehealth, not only for evaluating patients, but also for dispensing medications. Next slide. So if we look at what what changed, so the title of the rule has been medications for treatment of opioid use disorder, and the language, part of the language is very important, not to use stigmatizing language. And so some of this replaces outdated terms such as detoxification and adds new definitions. And I should add that we recently did, as I said, focus groups in a methadone program in Buffalo looking at stigma related to Hep C. But what we found was that some of these changes are now having an effect, at least in this one methadone program, to really make it much more patient-centered and to try and remove the old nomenclature of liquid handcuffs or other ways in which methadone has been referred to in the past. And I think some of these changes go towards that. Next slide. So the final rule, as SAMHSA calls it, also eliminates the 1-year opioid addiction history requirement and promotes priority treatment for pregnant individuals. So it also changes in admissions and removes barriers to medication access by focusing on patient needs. So you don't have to have a documented 1-year history of use before you can get the medication. Next slide. It also adds patient-provider shared decision-making and harm reduction principles into all care plans. And so this recognizes the need to meet patients where they're at. Next slide. The final rule updates the criteria for methadone take-home doses and allows patients to receive take-home doses from the first week of treatment under certain conditions. So these are changes that were permitted during the COVID-19 flexibilities. and demonstrate wider access to methadone with improved outcomes. So one of the big problems before, or limitations, restrictions, was the very strict need to come once daily or once weekly, and even sometimes on Saturdays and Sundays. And so the guidance is directed towards improving and reducing some of that. Next slide. So it also allows screening for buprenorphine via audio-only or audio-visual telehealth, and for methadone initiation via audio-visual telehealth. And it suggests that telehealth is an evidence-based practice that can expand access to care. My discussion in my talk in a few minutes following the session will focus on telehealth and telehealth use in treatment of Hep C primarily, but it has implications for treatment of opioid use disorder. Next slide. Interim treatment is now allowed at any qualifying opioid treatment programs, and the time frame for interim treatment was expanded from 120 days to 180 days, so 6 months, which again increases flexibilities. Next slide. It recognizes accreditation bodies as clarified in terms of reporting timeframes, follow-up on OTP implementation of corrective action, and communication with SAMHSA. So the idea here is to standardize some of these, to improve monitoring and uphold quality standards at OTPs. Next slide. It sets forth, so now OTPs are generally allotted 180 days following a receipt of a survey for corrective action. And so this allows continuity of operations if compliance issues arise while restoring full standards. So in other words, it gives OTPs more time to adjust to reporting problems. It also expands the scope of practice and allows nurse practitioners and physician assistants to order medications for opioid use disorder dispensing within the OTP. And so it allows for flexibility for provider staffing to improve access, especially in underserved areas. And so I hope that I've given you an overview of some of the lay of the land in terms of where we are with hepatitis. We're making important strides in A and B, as I showed you. Hopefully C, which is sort of plateaued, will continue to decrease. And I think some of these new rules or regulations and improving flexibilities, expanding treatment access, removing restrictions in terms of 1 year requirement for before somebody can be treated, giving more time for corrective action, I think are really trying to make a statement that we need more of these people to have access to these life-saving therapies, not less. And I'll leave you with one final thought, which I'll touch on in the next section, which is that can opioid treatment programs or substance use treatment programs in general really be thought of as health homes or deliver whole patient care? And I think that's at least in New York State, that's an approach that SAMHSA, that New York State Office of Addiction Services and Supports is really trying to promote. And with that, I'd like to thank you all for the opportunity to present to you today. Yeah, I'm happy to take any questions. Yes.
Dr. Paulo, thank you very much for this, and I am so excited to see the direction this is going. I just had an opportunity to check my email, and I saw that SAMHSA has awarded $98 million for the Hep C elimination initiative pilot. Are these going to be included in that? Is this the totality of it? Or can you give me just a Reader's Digest version of what that is, and whether or not you're going to be impacted by that?
I think the funding definitely helps. It continues to promote this as an important area. I think the bill that is currently in the Senate has not yet been introduced in the House. There was a call from National Viral Hepatitis Roundtable yesterday, and Daniel Raymond, who I know is a good friend of this organization, laid out several pathways for potential approval of that bill at the end of the year as an omnibus, so I think while the SAMHSA money is certainly very much appreciated, we really need much more emphasis in terms of where we can go to really eliminate Hep C. And it's encouraging that A and B are doing well. Let's see if we can continue to promote the C, and hopefully that will follow. Other questions? Okay. Well, thank you very much for the opportunity to speak with you.
Hold on, Dr. Salah.
Ah.
Sorry. Am I projecting loud enough or do I need the mic?
I hear you.
I was just going to say, especially on your last comment, as Hep C is still stigmatized so heavily, do you see if is there a way frontline workers and other people can get civilly engaged to kind of wrap our arms around Hep C in this world to make sure that practitioners and people who are providing care do understand the morality that is seen as a failure around Hep C, is seen as something that is because of someone's choices, and is there something that we can do and bring into our practices that can kind of uplift that and destigmatize? I'm probably preaching to the choir in this room, but I do think that even SAMHSA's funding speaks to where we still are.
Yeah. I definitely, and I think there are multiple parts to answer that question. The first one, let's take it, is what is the meaning of a Hep C cure in the DAA era? And what we found, I'll discuss this a little bit in the next section, but I was the PI on a large 600 patient study of telemedicine in methadone programs over the last 8 years in New York. 12 programs throughout the state, 6 in New York City, 6 upstate. What we found in both arms, whether it was telemedicine or usual care referral, is that a cure from Hep C was a win. And it allowed people then to address other whole health, family issues, get jobs, buy houses, get married. These were the stories we heard. We also followed patients for 2 years after the study was completed at the request of the PCORI, the sponsor, and we saw minimal reinfections. Only 13 out of 344 people who achieved a response, SVR. So it offered an opportunity to teach people, if you're going to use, at least use safely, avoid. And so I think a cure becomes an opportunity to speak to them. We did focus groups now, which was just published yesterday, 5 years after, with 9 patients in 2 methadone programs, and these what we had learned 6 months after they were cured persists for 5 years. So I think this is a long-term, showing the value of an SVR. In terms of other work, what you really need, I think, is to think about it as a community. In other words, that treatment needs to include caretakers, loved ones, the injection circle, the peer pipeline. I mean, all of the people who are important for those who are infected is a very important message to help them to recover. And by dealing with it and by explaining it's a disease, it's a medical illness, it's not a moral failing, hopefully you can have some benefit in that. In some of the work we did, the patients told us, I was at my house and my mother's following me around with a bleach can because I think that I'm going to, or other, that was one example, but, patients, family and friends following them around thinking they're contagious like in COVID time or others. So I think the education, linking, and discussing it as a medical problem is perhaps at least some basis to improve that. Yes?
Isn't there a vaccination that may be coming out for
Hep C has been phenomenally the question was, is there going to be a vaccine for Hep C? Hep C's replication rate is so much greater than B, it makes it phenomenally difficult to develop a vaccine. A lot of people have tried, but there has not, as far as I'm aware, we're very far away from that. Yes. Why is hepatitis A still prevalent in Pennsylvania? It relates mostly to foodborne outbreaks, and so inadequate sanitation. Yeah, you know, and so it's something to be aware. Just be wary of. I mean, I don't think you have to change your practices. There are inspections that are ongoing, but just be aware of that.
Hepatitis A is also prevalent in Pennsylvania because we do not get free hepatitis A vaccines from the state anymore, and we don't vaccinate a lot of people, and the pharmacies won't give them because they won't reimburse for them, so many people go unvaccinated for hepatitis A.
Thank you.
Any more questions?
Okay. Well, thank you very much.
Thank you, Dr. Talal.
Thank you, Dr. Talal. That was very timely and informative, and I appreciate the dialogue and questions. We have lots of experts in this room from many different aspects, so please have the dialogue. Well, it is now my pleasure to introduce the moderator for this session. I'm looking around the room. Oh, there he is. Okay. The moderator for our second session, Clayton Rowley. Clayton is the Director of Strategic Initiatives, Mission Advancement, and Impact with the Community Liver Alliance. And Clayton plays a central role in advancing our mission, working at the intersection of advocacy, harm reduction, and community engagement. He brings a wealth of experience in building partnerships across healthcare, public health, and grassroots organizations, always centering the voice of people with lived experience. We learned so much from Clayton. In his work with the Community Liver Alliance, Clayton has been a driving force in shaping programs that tackle health disparities, expand access to care, and strengthen advocacy around policies that impact patients and families living with liver diseases. We are fortunate to have Clayton on our leadership team and guiding today's conversation. Please join me in welcoming Clayton Rowley as our moderator for this important session.